الصحيح الذي رواه عبد الله بن مسعود: اغدوا عالمة أو متعلمة أو مستمعة ولا تكن الخامسة فتهلك. قالوا: زدتنا واحدة، فما هي؟ قال: أن تبغض العلم والعلماء، أن تبغض العلم وأهله. وقال علي بن أبي طالب رضي الله عنه: قوام الدين والدنيا على 4 نفر: عالم مستعمل علمه، وجاهل لا يستنكف أن يتعلم، وغني لا يبخل بماله، وفقير لا يبيع آخرته بدنياه. وقال رضي الله عنه: العلم أفضل من المال، فالعلم يحرسك وأنت تحرس المال. العلم حاكم والمال محكوم. العلم يزكو بالإنفاق، والمال تنقصه النفقة. وسئل أحد الصالحين أو أحد العلماء: العلم أفضل أم المال؟ قال: العلم طبعا. قال: فما بال العلماء يطرقون أبواب الأغنياء؟ قال: لأن العلماء يعرفون قدر المال، والأغنياء لا يعرفون قدر العلم. الواقفون على قمة الجبل لم يهبطوا من السماء، قال اينشتاين. الواقفون على قمة الجبل لم يهبطوا من السماء. كل نهج علمي سرنا فيه ووصلنا إلى نقاط معينة، رغم أننا بيننا وبينهم كثير وأمامنا طريق طويل، لكن على الأقل يكفي النية، يكفي إن احنا نذهب لنتعلم. لا يبخل العالم بعلمه ولا يستنكف الجاهل أن يتعلم. الأستاذة الدكتورة أميرة عبد المنعم هتقدم الدكتورة نيرة هزاع. تفضل.
شكرا جدا أستاذ دكتور سعد، يعني مقدمة رائعة فعلا، تأثرت جدا. ودلوقتي I have a great honor to present my dearest colleague Professor Nayera Hazaa, Professor of Pediatric Hematology Oncology عين شمس University، ويعني cornerstone في الهيماتولوجي Oncology Clinic، وهتpresent a very important topic which is inhibitors of hemophilia clinical perspectives. تفضلي دكتورة نيرة.
First, I would like to thank Professor Dr. Hazaa Abdelgawad and the organizing committee for giving me the chance to give this lecture in this eminent conference. And thank you, Professor Dr. Amira, for this kind presentation. I will start my talk. My talk today is about inhibitors. I will address the clinical side of inhibitors in hemophilia. This is my agenda. And I will start by talking about real-life clinical cases which were challenging in our hematology clinic. The first case was a 7-year-old boy with chronic hemophilic arthropathy of right knee. He was followed by my dear Professor Dr. Niveen Gamal and was subjected 3 times to intra-articular injection of rifampicin in 2015, complicated with intra-articular hemorrhages and later on fixed flexion contracture of the right knee joint. He was a candidate for posterior release and supracondylar extension osteotomy of the right femur as advised by our orthopedic staff in 2016. Unfortunately, 2 months later, the patient presented with a right mid-shaft femur fracture. A fixation surgery was planned, and before surgery, he was screened for inhibitors, and the test came back positive with a high titch of 64 Bethesda unit. The patient received recombinant factor 7 on the operation day. The first dose was at induction of anesthesia. The second was 3 hours later, and another dose was given after 3 hours. And then the patient was admitted in the ICU, received packed red cells and recombinant factor 7 at the dose of 90 microgram per kg every 12 for over a period of 7 days, with methyl prad that was shifted to dexamethasone, followed by tapering with satisfactory hemostasis, which was achieved. Since then, the patient experienced recurrent attacks of right hemarthrosis, for which he was giving recombinant factor 7 of varying duration. Last bleeding episode was in 2022 for a severe right side hematoma, which required 7 days of recombinant factor 7. The second case, well, he's now 20-year-old boy, but he was 14-year-old at that time. He had severe hemophilia A. He was receiving on-demand factor 8 replacement for joint bleeds. He had a history of an episode of iliopsoas hematoma, for which he required the hospital for 2 weeks of factor 8 replacement. And received cryoprecepted for it. In 2019, he presented to the ER by an acute abdomen with progressive pallor and limbing. On examination, the patient had severe pain, pallor, tenderness over the right iliac fossa, and painful limitation hypoesthesia of the anterior aspect of the right side. His pelvic abdominal ultrasound and CT showed a large right-sided iliopsoas hematoma, and the patient was admitted in the hospital and received packed red cells and factor 8 replacement at the dose of 50 international unit every 8 hours for 5 days. The follow-up ultrasound did not show any resolution. In fact, the patient was still complaining of severe pain. He was shifted to extended half-life factor 8 at a dose of 100 international unit, but still there was no clinical or radiological improvement and even no correction of the clotting test. At that time, we searched in his file for any evidence of inhibitor positive test, but the parents were requested several times to do the test, but they did not do it. So we have decided to start the patient on recombinant factor 7 treatment every 6 hours at a dose of 90 microgram per kg per dose. And after 3 days, the ultrasound showed a significant decrease in the size of hematoma, and the frequency of the recombinant factor 7 was decreased gradually, and the patient remained on recombinant factor 7 for a total duration of 10 days until complete clinical and sonographic resolution. After his discharge, he was tested for inhibitors and it was positive. And since then, he was given recombinant factor 7 of varying duration for breakthrough bleeds and continued while on emicizumab, which he started since 2020. The third case is a 12-year-old boy with severe hemophilia A. He was diagnosed in 2012. And this was the first exposure age at the age of 2 years. And over the following 7 years, he had recurrent episodes of hemarthrosis, gum bleeds, muscle hematoma, for which he received on-demand factor 8 replacement, whether plasma-derived or recombinant. He had an episode of hematemesis in 2015. And in 2018, he started low-dose prophylaxis factor 8. But at that time, he had left knee and elbow target joints. Unfortunately, in 2019, when tested for inhibitor, he had positive inhibitor, and he started recombinant factor 7 treatment for his musculoskeletal bleeds. But in 2022, the titer was persistently rising, and he developed right elbow target joints. At that time, my dear colleague, Professor Dr. Iman Ragab, gave him a trial of ITI, but the patient was non-compliant, so he was scheduled again for emicizumab. Now, talking about the inhibitors in hemophilia, I would say that it is a major complication of replacement therapy in hemophilia A. The formation of inhibitor occurs in 30% of severe hemophilia, 5% in mild and moderate forms. In PUPs, the previously untreated patients, the inhibitor can occur within the first 10 to 15 days of exposure, with 95% of the patient developing the inhibitor within the first 75 exposure days. In hemophilia B, the inhibitors are much less frequent and affect only 1 to 6%. So I have to suspect inhibitors when the patient with hemophilia failed to respond adequately to factor replacement, particularly in those who were previously responsive. And this will increase the risk of uncontrollable bleeding and will make treating bleeding episode more difficult. It will increase the disability, it will make the quality of life of our patient poor, and even cause premature deaths. Talking about the pathophysiology behind the development of inhibitors, this is factor 8. As we all know that the factor 8 was formed of 5 domains, A1, A2, and A3, C1 and C2, and B domain. If the inhibitor is to be formed, it is a high affinity immunoglobulin G, particularly immunoglobulin G4, which also do not fix the complement. But if the antibodies are against the C2 domain, it will affect the binding of factor 8 to phospholipids, as well as von Willebrand, and it will affect also the cleavage of factor 8 by the thrombin and the active factor 10. If the antibodies are against A2 and A3 domain, it will disrupt the interaction of factor 8 with activated factor 9. So it starts first by the central tolerance for a deficient protein. If we have an immature T cell, as we all know, in the thymus, it will differentiate into T cells that recognize self-antigen and T cells that do not recognize self-antigen. So in patients with hemophilia A with a genetic mutation, these patients are unable to express large portion of factor 8. So they are also not able to eliminate the high affinity factor 8 reactive T cells. So these T cells which are reactive will populate in the tissue and will produce the inhibitors. Upon exposure to factor 8 infusion, the factor 8 will be endocytosed, cleaved into protein, and presented by CD4 positive T cells. And this will activate the T lymphocytes. And according to the cytokines released, if the cytokines are gamma interferon, interleukin 12, this will increase the possibility of formation of inhibitors. Also, the activated T lymphocytes will activate the follicular B lymphocytes into plasma cells and memory B cells. The plasma cells will produce antibodies, and the memory B cells will have a fast and rapid response to repeated exposure of factor 8 and will produce a large amount of inhibitors or immunoglobulins. What are the factors affecting development of inhibitors? First, I can divide them into two categories, either patient-related or treatment-related. Africans and Hispanic are twice as likely as white to develop inhibitors. Severe hemophilia A, as we said, 30% of hemophilia A can develop inhibitors. Patients with a positive family history of antibodies to factor 8 has a higher incidence to produce inhibitors. The presence of polymorphic genes related to the immune system, like genetic mutation related to major histocompatibility class 2 or polymorphism to interleukin 10 and tumor necrosis factor, and also the mutation related to the development of hemophilia, whether large, complete, or multiple factor deletions are associated with increased risk of inhibitors. The treatment related, first is the age at first exposure. The incidence of inhibitor development decreased from 40% during the first months of life to 18% at the age of 18 months of the first exposure to factor 8 replacement. And this was published by the Canal study in 2007. The occurrence of infection, inflammatory state, or surgery, what we call the danger signal on the first exposure to factor 8, the number of exposure days, and finally, the debatable factor, which is the product type, whether recombinant or plasma derived are related, as I'm going to discuss in the next slide. So these are the studies that investigated the risk factors for inhibitor development, starting from the Canal study that was published in 2007, investigating the age of first exposure, the danger signals, the exposure days, and the prophylaxis versus on-demand. And interestingly, they showed that 60%, that is a 60% decrease in the risk of inhibitor development in patients on regular prophylaxis. And also we have the Higgs study, hemophilia inhibitor genetic study that studied the effect of factor VIII mutation. The Rodden study published in 2013, which studied the product. They did not find any difference between the plasma-derived and the recombinant. However, they said that the second generation recombinant were associated with significantly higher risk of inhibitor development. However, there are some critiques against this results because a lot of confounding factors were not addressed. And the famous CPET study in 2016 investigating the product type, and we all know that they concluded that the plasma-derived factor VIII with a von Lebrun factor, which might have a protective effect against the development of inhibitor, had a lower incidence of inhibitor development than the recombinant factor VIII. So when to screen, this is the WFH recommendation 2022, at least every 6 to 12 months, and then annually for patients with newly diagnosed hemophilia A and B. Within 4 weeks of the last infusion, if the patient is receiving the clotting factor of more than 5 days. For patient with hemophilia A or B with poor or no response, or the patient had a lower than expected factor recovery or half-life. Preoperatively in all patients, because we need to plan his factor replacement. And finally, for patient with hemophilia B, who had an allergic reaction to hemophilia or to factor VIII therapy, including anaphylaxis and nephrotic syndrome. So the WFH recommendation 2022 to use the Bethesda unit or the modified one. And if we have a positive inhibitor, that means that we have a titer of more than 0.6 in factor VIII and a titer of more than or equal 0.3 for factor IX. Inhibitor measurement could be done during replacement, but with the same assay, but we have to utilize a heat treatment technique. And finally, if the patient is on the bispecific antibody imicizumab, the WFH recommend the use of chromogenic assay in order to, containing factor 10 in order to measure the activity of factor VIII. Now, how to manage the acute bleeding and to prepare the patient before surgery. Again, the WFH recommendation 2022, it's according whether the patient is a low responder, that means that he has a titer of less than 5, or a high responder. If he is low responder, you have to saturate your antibody or the inhibitor with a higher dose of factor VIII, and you have to use this formula in order to give him a loading dose, an additional 50 international unit or above the calculated dose in order to achieve a measurable factor VIII activity. But in high responder, you will have to use one of the hemostatic bypassing agent, recombinant factor 7 activated recombinant factor 7, or the activated prothrombin complex concentrate. Sometimes we can use in high responder who had the level falling as an emergency in the first 3 to 5 days before the anamnestic response to occur. You can use the same factor but at a higher dose. Patient with imicizumab, the WFH prefer using the recombinant factor 7 over the activated prothrombin complex for fear of the risk of thrombotic microangiopathy. The combination of sequential treatment should only be used in an experienced center with a close monitoring for thrombosis. It is also estimated that the activated prothrombin complex concentrate can lead to anamnestic reaction, although it is transient, but it occurs in 30% of the cases. And also there are some concerns for patients with activated prothrombin complex concentrate in patients with inhibitors for factor IX, particularly those who had anaphylaxis, because it contains the factor IX in the component. Now, this table, I did put this table not to favor one product over the other, but for the young hematologist to know if you are using the bypassing agent, you have to know the drawbacks and the benefit of each in order to individualize your therapy. some of the clinicians might prefer the recombinant factor 7 because it is a recombinant product with no risk of human pathogen transmission, and it is not associated with anamnestic response, unlike the activated prothrombin complex concentrate. It has also shown that the thrombotic events can occur in both, but it's a little bit higher in the activated prothrombin complex. This is why it is not preferable to use it with the antifibrinolytic, concomitantly with the antifibrinolytic agents. A very important benefit of the recombinant factor 7 is the use of small volume and short time for administration, unlike the other product. But I would have to say that the activated prothrombin complex, and based on the clinical trials, the ProFiber and the proof, you can use it as a prophylactic 3 times per week for patients with reduction in the rate of bleeding, unlike the recombinant factor 7 because of the cost as well as the higher frequency of administration. The first study to compare between the two products was the Phoenix study, and it was a comparative study on 48 inhibitors, and they used the 2 doses, or 1 of the fiber and 2 doses of recombinant factor 7 alternatively, and they found that they have the similar efficacy. However, they found that 10 to 44% of individuals responded more favorably to one or another product. This is a meta-analysis that was published in 2009, including 17 studies with 2 randomized controlled studies, including the Phoenix study, and 1 controlled trial, 3 dose comparison trials, and 11 single-arm studies, and they investigated 2,000 joint bleeds. They showed superior efficacy of recombinant factor 7 over the activated prothrombin complex at 12, 24, and 36 hours. But up till now, and the new recommendation of WFH, they do not, they are saying that if you have a patient with inhibitor hemophilia A and inhibitor positive, you have to follow your patient. If the patient is not responding, you might shift from one product to the other or intensify your treatment. The recombinant factor 7, as we all know, has a maximal activity seen within 5 to 10 days after infusion. It controls the bleeding at the site of vascular injury within 24 minutes. The initial dose is 90 microgram per kg at the dosing interval 2 to 3 hours. For mild to moderate bleeding episodes, you can use 2 or 3 injections of 90 microgram at 3 hours, or 1 single injection of 270 microgram per kg. But the duration at home treatment should not exceed 24 hours. In the preoperative setting, you can give it continuous infusion or as a bolus. And both show the same efficacy. A longer duration might be needed in major surgeries than invasive surgery and minor surgery. A successful use of recombinant factor 7 should be when you use the initial dose of 90 and you use it within the first 2 hours after bleeding, and with adequate dosing interval every 2 to 3 hours. This is a very interesting data that was published in 2017, taken from the UK database, showing that an initial higher dose of recombinant factor 7 could be effective, very effective than the standard doses in controlling the bleed, that you might not need subsequent or even decrease the subsequent number of doses. Now, to escape or fight, finally, I would say that the WFH recommends to give a trial of induction, immune tolerance induction for patients with inhibitor positive. It is effective in 70 to 85% of patients with factor VIII inhibitor. In the international ITI trial, they use the low dose as well as the high dose with the same efficacy. However, the low dose might require a longer time to achieve tolerance with more bleeds. So more recently, clinicians can begin the ITI immediately after inhibitor detection, no matter the titr is with good response, but the best practice is to start the ITI after the titr is lower than 10 Bethesda unit. It is also possible now to delay or avoid the ITI with the use of emicizumab prophylaxis with a very low bleeding rates. So my take-home messages: the development of inhibitors remains a major complication. The WFH has no preference in the choice of specific type of therapy, as current study indicates that shifting from one product to the other does not increase the risk of inhibitor. The WFH encourage you to use to choose the product based on the advantage of simpler administration, safety, and efficacy. Any breakthrough in patients with inhibitors, you have to look whether the patient is a low responding inhibitor or a high responding in order to plan for your treatment. Some patients with inhibitors may respond better to one bypassing agent more than the other, highlighting the need to individualize your therapy. Thank you, and I would like to thank all my unit. This is a very nice photo that was gathered by my dear friend and colleague, Professor Dr. Niveen. I like this photo a lot, not only because all my professors from whom I really do appreciate them, but also because everyone is smiling in this photo. Thank you.
قبل ما اشكر نيرة، بس يمكن في الفترة الأخيرة أنظار العالم كلها متجهة لميسي ورونالدو ومريم فارس هتحيي الحفلة ولا حسن شاكوش، فيعني الواحد بيقول هم العلماء فين من دول؟ بس بعد كلمة أستاذنا الفاضل دكتور سعد ودخلت أستاذتنا العالمة الأستاذة الدكتورة سناء يوسف اللي علمتنا يعني وادتنا كل العلم، وفي حضور الأساتذة الأجلاء حاسة إن أنا فخورة بإن أنا دكتورة. يمكن امبارح عمالة الأسبوعين اللي فاتوا أحضر المحاضرة وزعلانة أتفرج على كأس العالم ورونالدو ميسي ولا يعني، فالقصة شوية بتبقى فنشكر حضرتك على الكلمة، وإن إحنا هذا المحفل يحفه ويحوطه الملائكة. نرجع تاني لنيرة. نيرة يمكن يعني one من ال challenging issue and the nightmare of hemophilia الانهبيتور، بس I think now والinsurance يعني موفر كل ال breakthrough bleeding by Novo 7 and the prophylaxis for inhibitor by emicizumab. أعتقد النايتميرز ده قل كتير. وهرجع بقى لأستاذتنا وصديقة العمر وصديقة الكفاح الأستاذة الدكتورة عزة عبد الجواد. ما كانش ليها بس ايادي بيضاء على الجامعات، لكن حتى الانشورنس. الاستاذه الدكتوره كتبت اول بروتوكول للهيموفيليا بخط ايديها، وبحط فيه المحاضرات بخط ايدك يا دكتوره عزه. كتبت لنا اول بروتوكول للهيموفيليا في الانشورنس. يمكن الدكتوره عزه معانا في الجايد لاينز في الانشورنس، ومعايا في كل، يعني انا بتشرف ان انا اللي معاها في كل حاجه. حتى دايما بيقولوا لي هو انت ما بتعرفيش تتحركي من غير الدكتوره عزه؟ طب استنوا لما اسال الدكتوره عزه.